Welcome all. Good morning. I'm Helen from TRACS, and I'd just like to start by acknowledging the Noongar people whose land we meet on today and pay our respects to elders past, present and future. So I'd just like to introduce our panel members. Jackie Garton-Smith is GP and co-lead of the Cardiovascular Health Networks. Nick Stoyanov, cardiologist at Royal Perth. Joanna Clark is heart failure nurse at Sir Charles Gardner. Robin Fowler, cardiorespiratory physio working at Royal Perth. Peter Goldswain is standing in today. He's a geriatrician and semi-retired, but he's standing in for Ewan Moodley, who we met with last week, and will speak on behalf of the respiratory physician with the backup of his other experts. Anita is community physio, Anita Dinsdale, and Louise Paps from community respiratory. We're just going to start by looking at the case study for today. John is actually a patient of one of the panel members. He's 69, a retired painter, lives with his wife in Leaderville. He has a family history of ischemic heart disease, hypertension, hypercholesterolemia, obesity. He's an ex-smoker. He ceased in 1992, and he had 40 cigarettes for 35 years, so that's 35 pack years. He also has a history of obstructive sleep apnea. So in 1994, he was diagnosed type 2 diabetic. He's poorly controlled, and he's now on insulin as well as metformin. So he doesn't look after his diabetes real well. 1995 was when he got diagnosed with his ischemic heart disease, which resulted in a bypass, a coronary artery bypass by 4 in 1997. He had further chest pain and represented in 2009, and he had an angiogram, and his venous vein to his circumflex artery was occluded. His left main and his LAD, his left anterior descendant, are all good. 2012, he presented with flu-like illness to the GP and was treated with Lasix for presumed pulmonary edema. 2012, he had pulmonary function tests which were consistent with mild COPD. And also in 2012, he was diagnosed with obstructive sleep apnea, but declined treatment. So John presented on the 2nd of April this year to the GP, but it was a Saturday morning, so it wasn't his usual GP. And he had increased shortness of breath, and he felt short of breath when he lay down to sleep at night. So we're going to take you on John's journey, starting with Jackie as the GP comes to see.
Thank you, Helen. I look at that list and I think it looks complex, but then when you read through it, he's actually quite a common case. Has everyone seen people like this in their day-to-day work? Yeah, it's a really kind of common constellation of conditions to go together, particularly for an ex-smoker, of course. So I suppose the challenges as a GP, apart from the fact that it's Saturday morning for this man's presentation, which really does complicate things out in primary care because we don't have the same sort of access to urgent tests. So really the first diagnosis, particularly not being this man's usual first priority, is to make some sort of preliminary assessment and decide whether or not he needs urgent treatment. So with I mean, obviously with someone who's presenting with a week's sudden increase in shortness of breath, the first thing we'd be thinking is what has gone on to acutely make this gentleman worse. And certainly he has a lot of possible reasons. He's got heart disease, he's obviously got a history that sounds a bit like pulmonary edema, so he might have some heart failure. He's got a history that's consistent with mild COPD, so that might be kicking in, and he's obviously got his sleep apnea as well. But in an acute setting, I'd also be wondering whether this gentleman's had a recent acute myocardial infarction, triggering perhaps some heart failure or breathlessness, and I think we always need to keep pulmonary embolus in the back of our mind with increasing shortness of breath, although the fact that when he lies down it gets worse does sound more like heart failure. So I'd be certainly assessing him for signs of heart failure, checking his observations, saturations if it's available in the practice, ankle swelling, jugular venous pressure, auscultating his chest for any crackles, also obviously for any wheeze or infection that may be contributing. But depending on those findings, and I'm not sure if we've got a slide summarising those, depending on those findings, I'd be thinking on a Saturday morning with if his situation is if he's sufficiently compromised, that probably a hospital setting would be better for him. And given that, I think Helen said he'd presented with his wife, so if he's got someone to drive him, then he may be able to make his own way there. But if he's really acutely unwell, then it might be a matter of calling an ambulance. So, thank you.
As Jackie alluded to already, sometimes the difficult decision can be really deciding what to do with this gentleman at the time that you're seeing him on a Saturday morning. Clearly doing investigations beyond your initial physical assessment will be challenging. So access to things like x-rays and following up, ultimately sometimes just make a pragmatic decision that this gentleman is too unwell to be managed as an outpatient, and indeed it's much quicker to assess him in a hospital setting where we have all the tests available at our disposal. So as a cardiologist, if I didn't know this man, can be difficult not having all their investigations available to you. And sometimes a lot of the challenges are just really following that up and chasing up all the old data. But assuming I'm his cardiologist and I know this man, my initial approach will be just determining what is the diagnosis. Is this definitely heart failure? Is this pulmonary edema? Or, as Jackie suggested already, could it be something else causing an exacerbation, either a pulmonary embolism or perhaps worsening of his COPD? So I'll continue on pretty much along the same lines, just physical assessment. Clearly the history is very important. The fact that he has got a history of ischemic heart disease, a previous occluded graft, previously treated for possible pulmonary edema means that it's more likely to be heart failure, and the orthopnea does sound more suspicious for heart failure. So I'll be asking for other things that might have precipitated it, any chest pain, any angina, any arrhythmia, palpitations, and then your assessment for left heart failure signs, for example, crackles, third heart sound, as well as looking for right heart failure signs such as elevated JVP, edema, ankle edema, hepatomegaly, and then going on to measuring his SATs, blood pressure, of course, ECG, as Jackie suggested, looking for any arrhythmia such as atrial fibrillation, which can often precipitate heart failure, and of course blood tests and chest x-ray. So the chest x-ray, I'm not sure if we've got the chest x-ray available there.
Yes.
Will most certainly show signs of COPD, but I'll be looking for any evidence of interstitial edema, and we can see the x-ray on the right showing significant interstitial edema, somewhat asymmetric with a lot of alveolar edema. So pretty classic x-ray for acute pulmonary edema. There's no pleural effusions evident. It is somewhat asymmetric, so you will always wonder a little bit about an infective process, especially given his history of COPD. So you might want to inquire about sputum production, fevers. Blood tests such as BMP can be useful if that is very elevated. That can certainly be a useful marker and something that you can follow. If it's borderline, it's not very useful. If it's low, it can be useful to exclude heart failure, as well as we mentioned, the ECG. The other blood tests looking for deranged LFDs, thyroid function tests, inflammatory markers, full blood picture, UNEs, and then ultimately echocardiogram. I'm not sure if he has one available that is a previous one to compare to. But I would expect his echo to show both confirm the diagnosis. So if there is a reduced ejection fraction or a valve lesion, that would help confirm the diagnosis of heart failure with a reduced ejection fraction. But sometimes you have heart failure with preserved ejection fraction, which can be difficult. You can look for signs on the echo, but it can be difficult sometimes to confirm. As well as looking for the clues to the cause. So with a history of ischemic heart disease, I would expect to see regional wall motion abnormalities, which can, again, suggest that ischemic heart disease is the cause. Yep. So in this gentleman, we have a reduced ejection fraction, and we've got signs of akinesis of the inferior wall, suggestive of previous inferior infarct, and perhaps one of his grafts has occluded since the last time he was seen. In terms of management, of course, we'll treat him with diuretics initially, so intravenous furosemide, oxygen, nitrates, depending on his blood pressure. And if he's really unwell, we'll look at CPAP or non-invasive ventilation. And of course, fluid restriction, salt restriction, daily weights. And I'm not sure if his medications at this stage, but you'd want to check compliance with the medications, but he's already on irbesartan, which you would continue. There's no beta blocker there, so once he's euvolemic, you'd look at introducing that, provided his lung function can tolerate a beta blocker. Maybe a more cardioselective beta blocker might be better, such as bisoprolol. And of course, then I would involve the non-pharmacological side would involve patient education. So I would involve Joanna, maybe she'll speak in a second, and Robin with cardiac rehabilitation.
Yeah, so I'm Joanna Clark, heart failure CNS. It's the Charles Gardner Hospital. So when we get patients like this, our first, obviously, thought is to check the echocardiogram. Like Nick said, we are looking for a reduced ejection fraction of less than 40%. Not just that, we're looking for moderate to severe diastolic dysfunction. We're looking for, obviously, any valve issues as well. So once we've got that gold standard diagnosis from the echocardiogram, then we can go to the patient and obviously go through the home plan. I don't know if you have all got a copy of this home plan, but this is our kind of gold standard, and we say to all the patients, this is your Bible. You put this on the fridge every day. This is what you would adhere to. We also give, from the Heart Foundation, Living Well with Chronic Heart Failure. So that's a very good resource for the patient. We also have a DVD that is from the Heart Foundation as well. And it's very simple. It runs for 20 minutes. We show it all the patients if we can before they leave hospital. And it's sort of Janet and John. It's an elderly couple, and it literally goes from when they're in hospital to going home, and then he has an obviously episode of weight gain, and then he contacts his nurse and she gives him education. So it's very, very simple, very easy, and we find that the feedback from the patients that we show it to, it's very promising, and they actually can go online to the Heart Foundation and view it. Just we've got it in a DVD format. So we can show it on the ward. So if we're looking at fluid restriction, That really depends on how much furosemide and what classification, New York Heart Association classification of heart failure the patient's in. So to give a rough guide, if they're class 1, technically they don't have much heart failure symptoms. It's normally a class 2, 3 and 4. So, and that'll correlate to how much furosemide they're on. So if they're class 2, you're normally on 1.5 to 2 litre fluid restriction. Class 3, normally 1.2 to 1.5, and your class 4s are normally 1 litre and sometimes even less than 1 litre. So really depends. And some people are surprised that you have to include soup and ice cream and jelly and yogurt. All of these things constitutes, and in summer especially, watermelon also constitutes as a fluid. So very important that the patient counts everything, especially these boost juices at the moment, when obviously they get this drink and it's all pulped down. If you have a piece of apple, you only have the flesh, you don't have the core. You put that into a juicer, you're getting all of that. So you're getting excess fluid when you're juicing it. So we recommend they don't juice, obviously, the fruit and the vegetables. So we go on to the weight, and we say 2 kilograms in 2 days, but it's getting them into a habit. As soon as you wake up in the morning, you go to the toilet, you empty the bladder, you step on your scales, and you don't have to measure your urine output, because some of them get very hung up on that. They've got to measure the urine output as well as the weight. It's just the weight that they need to measure. And that is a really good way. First thing in the morning, could be in, as long as they're in similar clothing. At Charlie's, we actually give them a pack, and it's got a weight chart in there. It's got a fluid chart in there. It reminds them what constitutes as a fluid. So we give them the tools to obviously go home and to use that as well. Salt is a very big factor for the patients. Nick mentioned that they obviously have to salt restrict. You're looking at 120 milligrams per 100 gram of product, obviously sodium content. Again, if you've ever tried looking at labels, the patients, it's very difficult, and the writing's very small. So one of the tricks is you tell your patient, get a magnifying glass. Something simple as that for the elderly who can't really read the labels. But we say go for low added salt, no added salt. It's that, just simple things like that. But what we tell them, a thing is not salt substitute. There's a thing called low salt or salt substitute. You'd be surprised, cornflakes, 500 milligrams of sodium per 100 gram cornflakes. So we say wheat bix. We say there's so many foods that have got so obviously preserved with salt. But in the Heart Foundation booklet, Living Well with Chronic Heart Failure, it gives them alternatives. Instead of using salt, it's mustard and obviously herbs and garlic and lemon juice. So there's lots of alternatives that they can use to flavour their foods. On the home plan, it's got the signs and symptoms. So we need them to manage. For us, it's about self-management. Them owning it, them knowing their condition, knowing their signs and symptoms. So yes, it's the shortness of breath and the ankle swelling and the PND and the orthopnea. And when we ring them, how many pillows do you lie on at night? And is there any change? Do you wake up in the middle of the night? So it's all on there. We also mentioned medication. Anti-inflammatories are a no. So ibuprofen, non-steroidals. There's other ones, but the common ones tend to be obviously your anti-inflammatories that we tell them not to take. And don't stop your medications unless advised to do so off your cardiologist or your GP. Vaccinations. People are often surprised. Winter time is the worst time for your heart failure patient. We are normally inundated at this time of the year for obviously heart failure patients. So we tell them, get your flu vaccination, get your pneumonia vaccination. Yes, there's going to be some that obviously aren't keen to have it, but the majority should have the flu and pneumonia vaccination. We go through caffeinated drinks, obviously limiting the caffeine intake, and alcohol, and making sure if they've got ischemic heart disease, chest pain management, knowing how to use their GTN spray is also very important. So after we've done all of that, we would see them in hospital. Then we would phone follow up. Myself, my service, I run a nurse-led clinic, and I'll invite them to my clinic. I'll look at their medications. I'll do up titration. I'm not a nurse practitioner, but with the help of the registrars, between us, I have been known to get patients in to do up titration of their medication when it warrants it. And then my next thing is to refer them on to the physiotherapist. So,
Hi, just to refresh, I'm Robin Fowler. I'm a senior physiotherapist in cardiorespiratory physiotherapy, and I currently work at Royal Perth Hospital. So I'm going to take you back to the inpatient part of this patient's journey. He was admitted on Saturday. I would touch base on Monday, talk to the nursing staff about how well he was. If he's not requiring non-invasive ventilation, CPAP, then we would probably be looking to start to mobilise him and to provide him with a progressive walking program. So that would be the tack to actually start to get him up and moving. The other thing I would do is a respiratory assessment with his history of COPD, his chest x-ray changes, which are not uniformly bilateral, and make sure that he didn't have signs of a chest infection with excessive sputum production and difficulty with airway clearance. So he would have a fairly thorough respiratory and exercise assessment, including history and current presentation. In fact, when I see this patient on the Monday, he's oxygen dependent and requiring oxygen to walk to the bathroom and to shower because of desaturation when he's off oxygen, so on room air, and increasing desaturation during activity. So it was I would walk him on supplemental oxygen for his walking program, and we would do that. I would do that according to his symptoms, so his breathlessness, as well as his signs, heart rate and blood pressure response as he mobilises. I would see him when I could during his inpatient stay. That's likely to be interrupted with investigations, but I would set him up so that he became independent with an oxygen cylinder if he remained oxygen dependent, which in this case he does, so that he can actually do some walking to maintain his exercise tolerance as much as possible and to limit deconditioning. I'm going to assume he's got some excess sputum with his COPD, but that he's independent with his airway clearance, and so I would just touch base with him on that basis and make sure that he was managing that okay. I'm going to now leap forward a week and say the following Monday, I come back after the weekend, the patient's still on oxygen or oxygen dependent at rest, so his saturation on 2 litres of oxygen is only 92%. So he still requires oxygen at rest. And when he walks, he desaturates when he starts to move a little bit faster. So at that point, I would be thinking the medical staff were probably trying to wean him from oxygen for discharge. They would be aware that he was oxygen dependent, but probably to add to that, what I would do with him is to take him for a 6-minute walk test, which was symptom limited and as he tolerated, and determine what happened to him in terms of his oxygen saturation, heart rate, blood pressure response and symptoms during the walk test. This particular case desaturates on his walk test, so he walks on 2 litres of oxygen, so the resting oxygen supplementation he's receiving, but in this case he desaturates to 85%. He's severely breathless at the end of his walk test. His heart rates rises moderately, a small to moderate amount. His blood pressure remains stable. He reports mild lightheadedness, no chest pain. And at that point I would talk to the team, talk to Nick and say, this man remains oxygen dependent and requires perhaps increased oxygen for exercise. So then suggest that he wasn't going to be an easy discharge based at least on his oxygen requirements and his ongoing symptoms, despite the fact that he's had investigations and up titration of his heart failure medication. Any questions to that point? No? So I'm going to now give you to Peter. I'm just thinking the order of this because he's going to go to Peter and I'm actually going to probably ask Peter to send him back to me. So I'm just thinking that out loud.
Yes, I'd been prompted that way as well. Yes, I'm going to, as I said, I'm a surrogate for Euban today, and I'm going to have to use props. I mean, I am a geriatrician, and this man is in the geriatric age group, but very much a cardiorespiratory problem, so I'm going to have to use the whiteboard. Hear me all right? That's fine. He's done a very nice little algorithm of how we approach this man. We know that we've done with his cardiac problems, and Robin has alluded to his respiratory problems. He's had... at some time, he's had pulmonary function tests, and his FEV1 is 50. So his FEV1 is 58%, and his FVC is 96%. All right. So the suggestions are that he has obstructive disease, and his SATs at the moment are 92% on oxygen, 2 liters of oxygen, and 85 on room air. So he desaturates and he clearly needs oxygen. And I think the approach to this man, given his obstructive airways disease, is the use of an algorithm, and it's nothing to do with me, it's called GOLD. None of us on the panel know what it stands for. We think the OLD stands for obstructive lung disease, but we're not sure what the G stands for. Global. Very well, global, that's obvious. All right, so there are 4 standards or 4 levels depending on his FEV1, and the 4 are, if his FEV1 is greater than 80%, he's level 1. If it's greater than fits between 50 to 80, and I'll move out the way so you can see this better, it's level 2, it's from 30 to 50, it's level 3, and if it's less than 30, it's 4. This makes sense when the respiratory physicians have a very nice box in which they divide into 4. So if he's, depending on his severity, if he's either 1 or 2 or 3 or 3 or 4, and then we have A, B, C, and D. And if he fits into A, so you can understand there, his FEV1 sits in that area over there, and in A or B, if he's in A, all he needs as treatment is Ventolin PRN. All right, so that's Ventolin. Okay, B, C, and D are all long-acting muscarinic inhibitors or long-acting beta agonists. Right, and then he uses inhaled corticosteroids for exacerbation. So that to a geriatrician actually makes good sense. It's the sort of stuff that we rely on. All right, so that covers his management there. He will clearly need oxygen, and that's where I have to go back to Robin to help me there. And Euban also mentioned that quite often, like in John's case, there's often coincidental disease, and the sort of things you're looking for are ischemic heart disease, anxiety, depression, and a psychologist, and that's where my colleagues are going to help me out through here. Osteoporosis is very much a geriatrician's line, so all his steroids he's on, you've got to worry about his vitamin D, his calcium, his falls risk, and so on, and check those out. And then frequent exacerbations requiring inhaled corticosteroids, and then lung cancer as we haven't actually mentioned it, but certainly when we'll look at his sputum and so on. And then we will need to consider, because he desaturates so significantly, we have to think about oxygen.
So this will have been an inpatient process, which would include blood gases. They might even have looked at his pulmonary artery systolic pressure to see whether he's got pulmonary hypertension, which will adjust the numbers that he needs to have an oxygen prescription. But we're going with the fact that this man is hypoxic and requires long-term oxygen therapy. He therefore will need an oxygen prescription and management through Silver Chain. So he'll have a referral for Silver Chain to actually help him manage his long-term oxygen therapy, and that will be set up prior to his discharge home. I'm unlikely to repeat a 6-minute walk test because we've established that while he's been moderately well treated he's been treated, he still has desaturation at rest and on exercise, that we would repeat that once he came into an outpatient program, which we would set him up for. So he'll go home on long-term oxygen therapy. And what I would do then is to have a think about whether he should go to a cardiac rehab exercise program, an education program, or whether he went to pulmonary rehab for exercise and education. Now, he's going to be seen by a heart failure nurse. He's been seen as an inpatient and he'll be followed up as an outpatient. So his education's pretty well covered in terms of his heart failure. We at Royal Perth Hospital, if he, with a history of ischemic heart disease, thought that he might want a refresher on his particular ischemic heart disease type management, for example, diet and management of his psychological issues and that sort of thing, then he could actually come to our group education session if he thought that was appropriate, and if Joanna had thought that was an appropriate thing for him as well. So we would liaise with our heart failure nurse to find out what the man's heart failure, ischemic heart disease educational needs are, and then set him up however that requires. Now, because he's oxygen dependent during exercise, we find it easier at Royal Perth Hospital to have him exercise in our pulmonary rehabilitation class because other people use oxygen. We've got cylinders that we can use so that we don't actually use the patient's own home supply. So I would most likely refer him to the pulmonary rehabilitation exercise class, but we would adjust our monitoring for him so that instead of just looking at looking at saturation and heart rate and breathlessness, we would also get him to weigh himself prior to each exercise session to look at his weight, and we would quiz him on his heart failure signs and symptoms, symptoms being chest pain. Just because he doesn't currently have any doesn't mean that he isn't at risk of having chest pain. So we would actually look for chest pain and lightheadedness and the sorts of things that we would look for in a specific cardiac rehabilitation class. And we would monitor his blood pressure more commonly or more regularly than we would for somebody who was pure respiratory pulmonary rehab program. So we would adjust our program according to this particular individual with clear marked cardiac disease and respiratory disease. Does that make sense to you? Yeah. The essence of the programs in terms of the type of exercise training and the intensity that he would undergo in either program is the same essentially. So it's looking at finding his limitations and providing him a program of initially light to moderate intensity exercise according to his symptoms and his response, heart rate, blood pressure, oxygen saturation and symptom response. So he would come to our 8-week pulmonary rehabilitation program in a tertiary hospital because he's complex. He's got a new diagnosis of oxygen dependence. Don't know if that's a diagnosis, but he's newly oxygen dependent. He'll need some education and some closer monitoring and then could be provided in the community. But following an 8-week program in our pulmonary rehabilitation program, I would refer him to our community physiotherapy service for a maintenance program, and I would refer him again to a pulmonary rehabilitation program, having done what we called a phase 2 program in the hospital. I would refer him to ANITA or to the community physiotherapy service for a maintenance program to further his improvements and continue to maintain his exercise tolerance.
So, yeah, thank you, Robin. Just to summarise, so my name's Anita Dinsdale. I work with community physiotherapy. I just thought I'd start by clarifying the difference between the grades of rehabilitation. So Robin mentioned phase 2. So I'm not sure if you were aware that there's phase 1, phase 2 and phase 3, pulmonary and cardiac rehabilitation. So phase 1 is the initial inpatient programme, and that can be cardiac or pulmonary. Phase 2 is as Robin mentioned, an 8-week programme, so more intensive, twice a week, involving education and exercise. And that can be done in the hospital. In this case, John's case, because of his complex comorbidities, it was an in-hospital, tertiary hospital setting. For the less complex, less high-risk patients, they can also go to community physiotherapy for a phase 2 programme. Because he was newly oxygen dependent, it makes it more easier to be done in the hospital because we don't have supplementary oxygen in the community. We rely on the patient's own oxygen cylinders. They have to bring them with them. Then he can be referred, which John was, onto a phase 3 programme, which is once a week. Again, it's cardiac and pulmonary, and our programmes are a combination of cardiac and pulmonary, so he can be catered for both comorbidities within the same class. So John came to my phase 3 program, which actually runs in Leederville, which is quite convenient because he lives in Leederville. They run the community programs are set up as an alternative to a tertiary hospital-based program because historically patients found it the engagement in rehab for cardiac and pulmonary can be a barrier, can be location. So they find it difficult to get into the tertiary hospitals, transport, parking, expenses. So the community programs have been set up around the metro, both north and south, in more convenient locations. So, for example, community recreation centres, sport and recreation centres, where parking is free, and they're also set up on public transport lines for those people that can access public transport. So being on oxygen is not a barrier to attending. He just needs to bring his own portable cylinder with a device to move the cylinder along. So in this case, John used, I think we agreed it would be a trolley that he can get from Air Liquide, which he pulls along behind him. But some people who are very breathless also use a four-wheeled walker, and their oxygen cylinder sits in the four-wheeled walker. I'm sure most of you have seen that. So the program provided with Community Physio is a weekly program supervised by a senior physiotherapist based on the 6-minute walk test and the distance that he was walking in the hospital-based program. John's target distance was around about the 900-metre walk. Because he was still desaturating even on the oxygen and becoming quite breathless, he needed to rest a couple of times during the walking program. So the walking may be continuous, or it may be interval trained, and the intervals may be based on symptoms, or it may be based on his oxygen levels. So we don't want him desaturating below 85%, so he would be encouraged to rest if his saturation's dropped. And the advantage of being in a supervised program with a senior therapist is that he can be monitored closely, and his exercise prescription can be adjusted according to his symptoms. One of the advantages of ongoing monitoring is that we can also monitor his other symptoms. So we can talk, as Robin alluded to, we can ask him about his weight. We wouldn't be weighing him in the class. We'd be encouraging him to self-monitor his weight at home, as was mentioned in the hospital setting, that he should be checking his morning daily weights. And he can report that back to the therapist, and we can then be advising him on what he should be doing. And if he's looking like his weight's increasing, if he gets to that 2-kilo weight increase, we'd be referring him back to the heart failure nurse within the hospital, or encouraging him to contact them. Or we might be referring him back to his GP if it was if he was getting symptomatic with worsening breathlessness, ankle swelling and some abdominal swelling. It would be a trip to the GP, or in worst case scenario, a trip in an ambulance to hospital. I have to say, in my entire 5 years of doing the class, I've never had to send anyone to the hospital. But that is our emergency response. We are in the community. We don't have a red button to press if there's an emergency. So our emergency response is a telephone and 000 call, okay? So for that reason, we do screen our patients quite carefully, and those that are appropriate to the community are those that are less likely to have an adverse event within the program. That said, touch wood, it hasn't happened. I'm not tempting fate by that. Okay. So the exercise program will continue for 10 weeks, and at the end of the 10 weeks, we would reevaluate John's progress. He hasn't reached the 10-week stage yet, as he was only referred into the program more recently, but at the end of 10 weeks, we would evaluate his progress. Because of his complex medical history, I would imagine John would not have reached self-management, because the ultimate goal is self-management and discharge, but he won't have reached that goal yet. He would probably need a continued program, again, the aim being at self-management. Within our program, we're also very lucky to be supported by Louise Paps from Black Swan Health, who's a respiratory linkage nurse. We will refer a lot of our respiratory patients onto the respiratory linkage service, because they can provide another link into other services and one-on-one care, and I'll let Louise talk about that in just one moment. I just wanted to very briefly, if I've still got time, to just touch on some of the benefits, particularly of pulmonary rehab and a cardiac rehab program. So improving peripheral muscle strength and muscle function, improving endurance, improving confidence and emotional function, improving mood, also socialisation. Some of these people can become quite socially isolated, which can actually make their symptoms appear much worse. And also improvement with adherence with medication, and Louise would also follow up on that. And again, ongoing monitoring of their symptoms, support, and liaison back with the health professionals at the hospital if we have any concerns. So we're another link with the patient and the acute services if that's deemed necessary.
So I run the Respiratory Linkage Programme, which is a community-based programme. Just to give you an overview, it is a nurse-led service. The idea is really to help the client understand their condition and to be treating it effectively and managing symptoms. So we can offer clinics, home visits. I do try and get people to come into clinic as much as possible because we're always encouraging that walking, and any bit of walking is good. But for those people that are severe, we would be able to see them at home as well. Okay. So initially, unfortunately, we don't always get the information that I get from CPS is pretty good, but unfortunately, it's not always that good. So I'd be trying to get discharge letters just to give me a bit of background. I'm often relying on the client to tell me about their condition and any other comorbidities that they might have. So it's very, very client dependent sometimes on their history, but we can get around that. So initially I would be getting a background history about their smoking. In this case, this gentleman has given up smoking. He's an ex-smoker, which is good. So we haven't got to touch on that. And also looking at what he may have done in previous work, as looking at why he might have a lung condition. We have. I would also be doing spirometry at that initial assessment, just so that I can confirm that he is moderate disease. So once we've got that information, I would be asking him what he understands about his condition, and from there on, I would be expanding. For those of you that don't know, the Lung Foundation are a fantastic resource, and I do point the clients towards that. All of the clients will be given this book, which is a very good overview about how to manage their COPD. Once he's understanding his condition, how to manage it. Within that, he's obviously on inhalers. Is he taking his inhalers properly? There's a high proportion of people that can't manage their puffers and don't take them appropriately. So it really is important that they all have their inhaler technique checked. If they can't use that device, then we'd be looking at perhaps another device that they might find a little bit easier. There have over the last year been a lot more inhalers or devices that have come out. This is a Lung Foundation again, and it gives you a good understanding of what devices are out there and what inhalers and combinations, because there's lots of different combinations too. So also, if they are on an inhaled corticosteroid, are they rinsing their mouth out afterwards? Because this can cause hoarseness of voice or oral thrush. So there's things like that we would touch on. I think in this instance, this gentleman isn't on an inhaled corticosteroid. He's also on oxygen. So again, he has been referred to Silver Chain for oxygen services, but we've seen he's had a hell of a lot to go through, and taking on board all this new information can be quite difficult for some people. So I would be going through his oxygen usage, how he should be using it, and the equipment, making sure he understands how to change the conserving devices on the top of the portable cylinders, making sure he carries a spare battery, because they're never told to. And if they run out, if the battery runs out, then they can't use their equipment when they're out. So there's basic stuff like that they need to understand. Also looking at the home situation. If their oxygen tubing becomes tangled, that's a trip hazard. So there are small devices that can fit in amongst the tubing called a swivel, and that will prevent the tubing from becoming kinked. So that's a trip hazard if it's left. So lots of things like that we'll be looking at as well. People with long-term oxygen are also entitled to an electricity subsidy, which is, I think, about $700-800 a year. So we'd be making sure that they have also applied for that. And that has to be applied for or signed by a specialist. Within the medication side of things, flu vaccination, pneumonia, we've already touched on that. So we're hoping he's already had these, or will be planning to have these things done. But that's something that we would be reinforcing. For a lot of people, they do exacerbate frequently. I don't think John, is he? He's not a frequent exacerbator, is he? I don't think, no. So that's fairly easy when we probably wouldn't touch on it. But for people that are, because this is a common problem, we do encourage action plans. And again, the Lung Foundation have got a really good action plan here. So the idea with this is to help the person understand their condition, understand what their normal is. Do they normally produce sputum, or are they normally non-productive? If they do start producing, if their sputum becomes green or yellow, then this is the plan that they need to follow. So that's for the infected exacerbations. And within that, they would be prescribed a course of antibiotics and or steroids that they could keep at home on standby. The problem historically is that people will sit on these infections or exacerbations and make an appointment with the GP probably the following week. But by then it could be too late. We do stress to people that with every exacerbation there is a potential for more lung damage. So they really should be treating these quickly and not messing around. So this enables the person to start treating and then get follow-up with their GP the following week. We do stress that this is something we should all be working together and not to just take them and not tell anyone that they've been sick. You can also have non-infected exacerbations, and in that situation it might be just a prednisolone that they require, but it really is about managing their condition. I can't prescribe, again, I'm not a nurse practitioner, so I would be working very closely with the GP and or specialist to make sure that that's completed for the person. From there on, he's already gone to pulmonary rehab, and hopefully that will continue as on a maintenance programme. However, if there are problems and he deteriorates or he re-exacerbates, ends up back in hospital, I would coordinate it so that he either goes through rehab in the home on discharge, or that we can get him back into rehab if he's well enough. So with the programme that I run, we don't tend to discharge people, which is quite a luxury because it is a progressive condition. We try to manage that and monitor people. So along with all those, we would be making sure, is he managing at home? Is he able to shower? Is he using his oxygen in the shower? So many times we see people don't use their oxygen in the shower, and those are the times that they're desaturating, and probably it's more beneficial for them. To try and give them some tips and hints that will help them at home, and also looking at whether they need a HAC assessment or a referral to ACAT, and have they got an ACROD, because they've probably got a lot of appointments to attend at the hospital. You might not be able to get there because it's quite a long way to the clinic room. And also, he's had a lot going on. I do routinely do depression scoring with clients. There's a high number of clients that do have anxiety or depression, and if that is not managed, then they're not going to be able to self-manage their other conditions. So that really is crucial to making sure they're managing well. We also did mention he had sleep apnea, and that he'd declined treatment in the past. So perhaps not initially, but later on we could revisit that, just check his Epworth score, which is a sleepiness score, and refer back in if needed. Other considerations, have I got time? Sorry, rabbiting on. He's diabetic, and it's been pointed out he's not managing his diabetes well, so I would look at referring him in to see a diabetes educator. I'd also be asking things like whether or not they're continent, because if somebody is incontinent, we can sort out pads or incontinence products through Silver Chain for them. Also steps if there's any chronic pain, and advanced care planning is really important. So again, that's something, there's a whole thing in itself. There are advanced care planning booklets which are really good, and that incorporates Advanced Health Directive. And if the person does decide that that's something they want to do, I would be ensuring that everybody involved in their care has a copy. So if they don't want to be resuscitated, everybody knows, because it's pointless them sticking it in a cupboard and not telling anybody. So really I'm there for the client just to as a support in the community, and to try and help them navigate the health system, and to try and help them self-manage and keep them at home and out of hospital. Thank you.
Thank you.
Sorry, I just want to, the continence issue I didn't mention, but in fact when the patient was in our pulmonary rehab program, that's one of the questions that we ask, is whether they have continence issues, and we can then refer them to our women and men's health physiotherapist, who can actually perhaps help them to manage any continence issues. So hopefully we've we've done that, but it may well turn up later because there's an overwhelming amount of other things happening. And so definitely, in multiple moments in this patient's journey, there are opportunities. The other thing is that if the patient has a readmission to hospital, we can start the process again of him going through another phase 2 pulmonary rehab program, or he could go to cardiac rehab if he ever if that seemed more appropriate at any point in time. So the multiple admissions, the multiple touch base in the health system is a really good thing at the moment, that there are times to pick the patient's particular issues up at that moment and to work with them.
Perhaps it's not an accident that there's a geriatrician on here, because when I hear things of all his comorbidities and things like incontinence, certainly we would play a very active role in management of that, perhaps rather than sending off to where you wanted to go.
Just one more very important thing. I forgot to mention, we also do have a support group, so I would be encouraging people, if they want, it's not for everybody, but that's it's a support group for people with lung condition. Anyone can access it, it's free, and it really is about helping the patient understand different things. So it might be, we do have a regular respiratory physician that comes in, dietitian, all sorts. So that's a monthly meeting. And the last thing, Peter's got a really good form. This is a Lung Foundation stepwise management of COPD. This is available, COPDX guidelines as well, and it's really good if you're not sure medication-wise. This is an overview of everything that the person with COPD should be getting and accessing.
Okay.
I don't know about you, but right now I'm thinking I made the right decision to refer this man to hospital to access all these wonderful supports that I would have had trouble getting kicked in the community. It is possible, but it's certainly for someone who's very unwell, it's a quicker way of mobilising it. Only poor John's now really got a full-time job again, just managing his medical conditions, and I certainly feel for him in that, particularly with having to go to hospital appointments and various exercise classes. And I think the GP still does have a really important role in helping John to manage, and John's family to manage all of this. The communication to us is absolutely vital. Both from the other services that are involved, because as a GP we'll be really guided by the specialist teams on what John's prognosis is, how to titrate his medications, particularly when they get more complex. And if you hear patients saying that GPs aren't helping them titrate their medications, it's often because the GP is not confident to do so. So give them a push, because we often hear GPs say, look, the hospital's managing that, the respiratory physician's managing that, the cardiologist is managing that, but it does have to be a team approach. We also certainly can encourage adherence to medications. The diabetes, as Louise mentioned, is sort of the missing link in all of this that needs to be looked after as well. So while he's getting a lot of support, he still may benefit from a GP management plan and team care arrangement to access some other allied health services on Medicare funding, such as perhaps podiatry, given his diabetes. And we can also put in place mental health plans to get Medicare rebated psychology services, should he require that. We certainly have a role in ongoing family support as well, and in helping John with his decisions around advanced care planning and advanced health directives. And certainly as people get more severe, I'll often say, have a plastic folder with a list of your medications and your advance, if they have an advanced health directive, your advanced health directive in it, sort of by the door where the ambulance will come past, because I have seen people collapse, an ambulance called and no one can locate the advanced health directives that says do not resuscitate. It's really important if that's what their wishes are. So, and finally, GPs are quite hard to get into. there is certainly an undersupply. So I would highly recommend that John makes regular appointments, longer appointments if he needs to, and has a low threshold for ringing for an appointment if he feels he's deteriorating. The other thing I often tell patients, and this may be helpful for you, is if you can't get an appointment, ask if you can speak to my practice nurse. A lot of us have practice nurses, and they're very, skilled at finding a way to fit in people who need to be seen, or indeed encouraging the patient to go to hospital if that's needed. There's just that next tier up of advice from what they can get from the practice receptionist. So, yes, I hope that's helpful.
Often when the patient has struggled to get an appointment, we've said, come back to us. We've rang the GP on behalf of the patient. And for some reason, we do hold a lot more clout, and we've actually been managed to get the patient in either that day or the very next day. So, yeah, if they can come back to us, we often would advise that as well.
So now I'd like to thank you very much. That's fascinating, and the patient's had a wonderful journey, and it's really great to show how convoluted one person can be. And I've had some questions from the people in the country. So for Nick, on the beta blocker side of things, could you speak to the beta blocker if you may have prescribed this for this gentleman in light of everything that's gone on?
Sure. I mean, this gentleman has ischemic heart disease and heart failure, so he's got very good reasons to be on a beta blocker. One issue we have initially is, of course, whilst he's decompensated, we generally might continue his pre-existing beta blocker if he's already on one, unless he's really in cardiogenic shock, for example, with a low systolic blood pressure or in the florid pulmonary edema. But generally, we don't introduce the beta blocker until he's stabilised. So that would mean once he's euvolemic and able to certainly get up and walk short distances at least, but certainly in the long-term management, beta blockers would be very important to reduce the risk of sudden death, as well as reduce the risk of arrhythmias, and of course improving his heart failure. So what I would do from a practical standpoint is, once he's in this particular case, it's a bit more difficult because he remains hypoxic. But once I'm confident that he can lie flat and maintain his SATs without being in pulmonary edema, I would start a low dose beta blocker. I mentioned before that it would be generally a cardioselective long-acting beta blocker. So that would be usually bisoprolol or the long-acting metoprolol XL, sometimes nebivolol, usually at a very low dose to start with. And we would only titrate it every few days or a week or so. So in hospital, you might do it after a couple of days, but as an outpatient, certainly you might wait a week or two between titrations.
Okay, and I'll have a question for the physios, so if you could pass the mic to Robin. From Geraldton, for inpatients who are being considered for ambulatory oxygen, we would focus not just on saturation, but also check if John can walk at least twice as far with the oxygen. In this case study, I'm assuming he would be too unwell to walk without oxygen for this test. It might be worth mentioning the statewide policy indicates an increased walk distance is necessary to show that the patient would benefit from oxygen. Would someone like to speak to that?
I think and the pulmonary rehab toolkit looks at oxygen therapy for exercise, and I believe, in fact, there are a number of options or a number of different criteria to allow oxygen to be used for ambulation or exercise. In the case of the inpatient who's had heart failure, which is being currently managed, who clearly desaturates during activity, I would be unhappy to have him exercise, e.g. walking and desaturating during that, when we can easily provide him low-dose oxygen, which is highly unlikely to cause him any adverse effects. I can have a look at the pulmonary rehab toolkit guidelines if you would like. Thank you. Louise, do you have any comments about oxygen and...
I think one of the comments that we discussed with John
Yeah.
was that because he's on his oxygen therapy, his resaturation time is quicker, which means that he's resting for less time, which enables him to walk for longer. So although he still desaturates and he still is breathless, as we know, there's no strong correlation between breathlessness and oxygen desaturation. You may have low oxygen saturation and not be breathless. You may have low oxygen saturation and be breathless. And oxygen doesn't treat breathlessness. Okay, so his breathlessness may not have changed, but what we found with John was because he was now on ambulatory oxygen, he didn't need to sit and rest for so long. His resaturation time increased, and that's what enabled his six-minute walk distance to then increase. Does that make sense?
Yep.
And I can actually read this to you. So this is from the Pulmonary Rehabilitation Toolkit. If the patient shows improved oxygen saturation or improved exercise tolerance or reduced dyspnea when using oxygen, supplementary oxygen should then be given in future exercise training sessions. And I would stick with that's actually really good advice. And this is evidence-based practice that's supported and provided on the Pulmonary Rehabilitation Toolkit. Do you have any further questions or comments, or anyone else?
The comment from Geraldton was that the question probably related to someone with purely lung disease as opposed to this gentleman who has both lung and heart disease. And I have a question. Oh, sorry. Yep, a comment, Louise?
I was just going to say that really for the lung clients, so the issue is that they often become deconditioned. So the breathlessness stops them doing these activities because, understandably, it's not a nice sensation. So they stop doing things over a period of time. Their muscles get weaker. So that really is where the pulmonary rehab is so important, and that we want to be getting the most out of them when they're at exercise. So if they were stopping repeatedly because they were desaturating, they wouldn't be getting the most out of their exercise. So.
Yep. I also have a question while you have the mic, Louise. The sleepiness score. They didn't catch the sleepiness score.
Sorry, yes, it's called an Epworth score. And it really is a sleepiness score, so it gives us an idea of how tired the client is. And from there, it's graded, so into mild, moderate, nil, mild, moderate and severe. So obviously if, alarm bells start ringing and somebody is moderate or severe, we'd certainly be referring back to the respiratory specialist or via GP, sorry. Epworth, without an E. EPWORTH.
Yeah, like the hospital. Epworth score for sleepiness. Another question. How can we manage John when he lives 300 k's from the nearest regional or metro centre? Oh, that might have come from the country people. Yep.
Obviously, we do telephone follow-up, and they can live 300 miles away, 200 kilometres. So
Yep.
distance is not a barrier. Yes, we can't physically get them into clinic, but we can refer to their nearest centre, and they're only a phone call away. So for our service, distance isn't a barrier.
Yeah, I'm just interested with technology. We now have a number of heart failure services that you can Skype into. You can have your appointment, over all this great new technology that we have. Is there anything for respiratory and cardiac patients out in WA that is telehealth?
I think telehealth certainly it's a big opportunity. We're using it sporadically, but it's not something that we've got particularly well established. And certainly there's a lot more that could be done. Certainly I've used it in the private sector, sometimes with the patients in the room with their GP, Skyping to the cardiologist. it lends itself very nicely to heart rhythm disorders, which is my other specialty, but certainly for heart failure, there is an element where you definitely need the examination which the GP can provide. Of course, you've got the weight and you've got the blood pressure, pulse rate, etc. So, absolutely, I think it's a bit of a missed opportunity, especially for country patients. But I think as our hospitals get a little bit better set up, it's something that hopefully will be utilised a bit more in cardiology. I know other specialties use it routinely a lot more than what we do. Maybe Peter can comment about other specialties. You use it in geriatrics at all, Peter?
Yes, I mean, yes, we do, but a lot of it is interview-based, which makes it much easier. I mean, as you're probably aware, when we see geriatric patients, we spend at least 3/4 to 90% of our time talking to patients and the rest of the time examining them. So that, by Skype and so on, aids considerably towards making a diagnosis and formulating a management plan. Absolutely.
In terms of an exercise program, probably the only option, if there's not telehealth available with a physiotherapist who's local, would be to actually make sure that the inpatient period for this particular patient was spent educating him on signs and symptoms to watch during exercise intensity that is appropriate, trading exercise, reducing exercise if symptoms became worse, looking at the things that would suggest that he was improving and the things that would suggest that he was actually deteriorating. And so there would be a lot more emphasis on inpatient education regarding exercise training. And the emphasis on that would be to actually teach the patient what he needs to know that I know or the physiotherapist knows, so that he can self-manage without having the luxury of an 8-week program and perhaps then a maintenance program where that education is a big part of that program. So it's a sort of short, sharp education session, which is easier said than done because, of course, there's an awful lot going on for this man during his inpatient stay, but a dedicated period of time every day to actually talk to him and to get him to talk back and to actually listen to what he's actually learnt and to help him so that he can manage his own exercise program independently as much as possible, and then perhaps to set him up for a review if he has to come back to tertiary hospital appointments, and to actually then follow him up on that basis.
Yep.
Just to go further on that, there's again the Lung Foundation, fantastic resource. They've got POMI rehab training online, and they've also got a COPD online training tool, which is really good. So for people that haven't got a lot of knowledge, that's a really good starting point. But they also do have patient education information on there. So as far as condition management, that is a really good resource for somebody living in rural.
Also, there is a spirometry online training program which has been endorsed by the Nursing Foundation as well. So I think there is a cost involved. But for rural areas that don't have pulmonary function facility within their hospital, there is an online training program that also can be done for spirometry and interpretation of spirometry as well.
I was just going to say as well, if this patient can access a local physiotherapist or other exercise professionals, such as an exercise physiologist who doesn't have, enormous skill in cardiac rehabilitation, then Heart Online is a wonderful resource to actually assist for a health professional to actually learn what it is that is current best practice for cardiac rehabilitation. So it's a great resource, Heart Online. Easy to access, easy to work through, very comprehensive.
It does seem, as an outsider, that your IT supports regionally are pretty good.
Thank you, Peter. Can I take some questions from the audience?
So if we're seeing clients and we do we refer to silver chain as
For South, yes, you silver chain respiratory, Catherine. Yes.
Do you want to fill us in?
Yep, Catherine.
Silver Chain is a metro-wide oxygen service. We have over nearly 1.5 thousand people requiring home oxygen on it. We have bases at Jandakot, Maddington, Peel, and then up in the north around Kingsley, Stirling. They're dotted all around the place. And for people to have oxygen, they have to be referred in by a specialist, and then we go out and we do monitoring at various intervals. We usually see clients every 3 months, so that there's a really strict follow-up pattern in what we do. And I think we've grown, the service has grown from 3, and there's now 13 people out in the field doing field work. So it's a good service, and it's a follow-up service, mostly with what Louise is doing, but also, we had people requiring humidification. We work up people for transplants, sleep apnea, headaches, to name a few, and palliative care, of course. I think there's at least 70 people on oxygen who are palliative.
Thank you for that. And again, I think, nowadays that the advanced care plan that's been touched on a couple of times is something that's really important that we discuss with our patients. And, if we're truly going to, and their families, if we're going to deliver person-centred care, we have to know what matters to them and how they want to deal with things as their disease progresses. Yeah. Another question? Beautiful.
I know we talked continence, but it's really the one thing that I see in what I do is the constipation. So we haven't actually touched on one of the biggest risks for these people, this group, because of the reduced fluid intake, because of reduced mobility, because of reduced all those other risks. One of the things that go undetected is the constipation, and it puts this group at higher risk of falling. So, and urinary tract infections and all sorts of other complicating factors. The other comment was I work with residential care line, so we go out to aged care facilities. This group of people are in their last severe stages of cardiac failure, pulmonary disease. Probably Nick, it's the question is the difficulty I have is convincing GPs to dump the fluid. Right, so they often got renal failure, chronic renal failure, and Peter and I have talked about this on numerous occasions, that you see their weight increasing, you see their jugulars starting to bound, and you see the pitting edema, and but then the GPs are often concerned about the renal function. So, there's a real balance, but at the end stage of disease, what's your opinion on that?
It really does come down to really the fluid assessment, and that's the bit that can be really challenging. Most of these patients with impaired heart function also have some degree of renal failure, and certainly monitoring their renal function can be sometimes quite worrying. So you do see their creatinine go up, their urea go up, and of course if they're still fluid overloaded, they still need diuretics, and they still don't need to drink as much fluid as we think. I suppose we do have it very easy in hospital, in the outpatient clinics, is that we've got a lot of other things up our sleeve that we can use to gauge their fluid balance. We can see patients day to day, monitor their weight. We do tend to sometimes impose quite strict fluid intake restrictions on them, but I find that most of the issue doesn't tend to be fighting with GPs. A lot of it is compliance on the patient's part. It's just extremely challenging to get patients to stick to even the 1.5 litre fluid restriction. I mean, Joanna can talk about that, but that's extremely challenging. I mean, patients are often cheat, so to speak, when it comes to that, whether that's drinking out of the tap and not. I mean, obviously at home it's a different proposition, but in hospital it's a challenge. So I can only imagine in home their compliance is going to be an issue. But at the end of the day, if they're fluid overloaded, they need diuretics and they need fluid restriction, regardless of their creatinine.
As a long-standing geriatrician, very few of my patients drink more than a litre of fluid anyway. I mean, you don't have to fluid restrict them because they don't drink much fluid. So, I don't actually follow that line at all. I just leave them alone because they don't drink much. End of story.
So this group of people, you're right, Peter, getting them
I'm
to
talking
drink.
of the
getting them to
elderly, yeah,
drink is
sure.
harder than not drinking. It's probably more the consideration of having Movicol instead of lactulose, you know, so what you're drinking and what you were talking about, Joanne. But this group of people, we often don't have to restrict. You just have to look. But they're getting to that final stage of disease, and it's a fine balance.
Yeah, so I suppose we might be talking about different groups of people. I certainly find that the patients with heart failure in hospital that are on diuretics do have a very dry mouth, and they tend to drink sometimes 3 litres a day because they just find that their mouth is constantly dry. But I think if you're talking about, I mean, certainly some patients, the elderly, etc., if they're only really drinking 1 litre a day, they don't need probably as much diuretic as what other patients need. So I totally agree with that, is that it comes down to their weight and fluid balance. And really, if they are only drinking 1 litre of fluid a day, then they'll probably get away with a lot less diuretics, and which is, of course, in the long run, better for their kidneys as well.
So it's balance, isn't it?
It's balance, yeah, exactly. Yeah.
So the only other thing we have come across for the dry mouth is biotine. Obviously, a mouth spray. It's normally used in cancer patients, and a few patients have actually recommended that that's actually a very good spray for the dry mouth to treat that.
I mean, I hear very much that part of the issue is not accepting that this might be an end-of-life situation, and I think that affects GPs attending aged care facilities sometimes as well, and it is hard to find the balance. But I worked many years ago for a physician who was really quite inspirational in the gently approach with aged care facility patients in terms of sometimes people don't like to see big decisions, but sometimes tweaking down the fluids gradually rather than kind of might be more acceptable to the GP, and might help more in finding that balance in terms of adjusting diuretics and fluids. So I don't know if that helps, but
It does.
yeah, thank you.
Thank you.
Well, I think we're close on time, and we basically sent round this diagram, and it was meant to have lots of arrows to show the complexities of this one gentleman who is common to us all. We've all seen John, we've all cared for John, and we've cared for lots of Johns. And yeah, it just shows how complex one person is, how many of us get involved, but he's also got his wife, his family, he's got his community, he's got lots of people to help him out too. So, and I'd just really like to thank the wonderful panel today. I've learnt so much myself, and I'm sure you all have in the room. Thank you.